Good evening, everybody, and thank you so much for joining our session and the Hereditary Clinic Workup and the BRCA Center for Research. If I may, I'd like to share my screen for a second to introduce some of our team members. Okay. Today's talk is about risk-reducing surgeries for breast and gynecological cancer. Our panelist is Dr. Chen and Dr. Edwin Alvarez from the Gynecological Services, Dr. Merisa Piper and John Rose from Breast Plastics, and Dr. Cheryl Ewing from Breast Surgery. And this is just the reverse order on how our panelists are gonna talk. I'd like to take a introducing our team from the Hereditary Clinic. I am the supervising oncologist. The clinic is mainly run by our fabulous nurse practitioners, Bethlyn and Glenna Lee, as well as our genetic counselor, Julie Mack and Marta Sabatini. Our research team is Dr. Leticia Tanibaki, is a fellow on my right hand from Brazil. Savannah Berkeley and Kelsey Cordero are our research coordinators. Erica Amy Samoy and Julie Cabrera are our practice coordinators. Because the workshop was initially labeled as a BRCA workshop, but we realized we have many of our patients who have who actually have mutations that are not just BRCA1, BRCA2, and PALB2, where the risk-reducing surgeries are focused on breast, ovarian, and fallopian tubes. In CDH1 mutations, we do breast risk-reducing surgery as well as stomach. We will not talk about stomach cancer tonight. For Lynch syndrome, we talk about uterus removal as well as ovarian removal. And our GYN team may address some of the questions on uterine removal or hysterectomies. For P10 is breast and uterus, BRIP1, RAD51C, and RAD51D. We offer risk-reducing surgeries for oophorectomies and fallopian tube removal, and for TP53 and STK11, this is mainly breast. And with this, I now would like to introduce Dr. Cheryl Ewing, who is a long-standing friend of mine, amazing breast surgeon. She will kick us off and talk about what does a mastectomy actually entail. And Cheryl, it's all yours. If you don't mind turning your camera on, you'll be live. Also, one of my panelists says P10 has risk-reducing surgery for hysterectomies. Cheryl, all yours.
Okay. Well, thank you, everyone. I just want to talk to you about the various ways that we do risk-reducing mastectomies. So first, after someone is identified at increased risk, either secondarily from their strong family history or an identifiable pathogenic genetic mutation, then we have multiple discussions about surveillance or surgery. If someone is interested in surveillance, that would include a breast examination every 6 months, a mammogram alternating with a breast MRI every 6 months, and it could include anti-estrogen pills or hormone replacement, a hormonal therapy. As also a preventative method. Now, as far as the surgery, we divided into two groups. One, someone who wants to proceed with a risk-reducing mastectomy. The next question is, are they interested in reconstruction? And my plastic surgery colleagues will talk to you a little bit more in detail about how we do reconstructions. For the mastectomies, if someone does not want a reconstruction, we'll do what is called a simple mastectomy, where it's just a simple removal of the breast, the overlying skin, and the nipple, and you're flat with an incision across the chest. If someone is interested in a reconstruction, then we offer either a nipple sparing or what we call a total skin sparing mastectomy, where we make this incision usually underneath the breast so that you cannot see it, but we spare the entire skin envelope, including the skin of the nipple. So when the breast is reconstructed, either with an implant or using your own tissues, it looks like a normal breast. It may not look exactly like your breast, but it will look like a normal breast. The alternative, if someone does not want to keep their nipple, which is a little unusual, but on occasion I do have patients who tell me they don't want to keep their nipple, then we excise the nipple, we preserve the remaining skin envelope, and then again the breast is reconstructed either with your own tissues or using an implant. So those are the various ways that we do mastectomies.
Thank you, Cheryl. And as you know, we will have a panel, and our panelists will have an opportunity to have a little bit of an answer on questions. But I think I'm going to push this back a little bit and let Dr. Piper and Dr. Rose speak a little bit more about what does reconstruction look like. Merisa, do you want to go first?
Sure. Hi, everyone. So whenever I see someone in clinic who is contemplating a prophylactic mastectomy, my typical spiel is that there are 3 pathways that someone can take. Pathway number 1 would be what Cheryl briefly mentioned, which is going flat afterwards. And that can either be going flat with a straight line incision across your chest, but it could also be going flat by trying to preserve as much skin as possible to maybe give a small breast bound afterwards. It's colloquially called Goldilocks procedure, but the idea behind that is preserving some breast skin and some subcutaneous fat to make the chest appear a little bit less concave after a mastectomy. Option number 2 would be to undergo implant-based reconstruction. And there's several branches within implant-based reconstruction. One option would be to put an implant in at the time of mastectomy. That is called direct-to-implant reconstruction. And in order to qualify for direct-to-implant reconstruction, you have to be the right candidate for that. So typically, those are women with smaller breasts and no ptosis. Ptosis is when the nipple is in a lower spot on the breast mound. In order for someone to be a good candidate for direct to implant, the nipple would ideally be more centered on the breast. So think of direct to implant as being a very limited subset of people who can qualify for that. More typically, we would place something called a tissue expander at the time of mastectomy. A tissue expander is similar to an implant in its footprint or the size of it, but it has a unique property in that there's a port inside of it that allows fluid to be added to make the expander grow. And so typically we would put that in a breast after mastectomy with very little volume. Once your skin has recovered from the mastectomy itself, we can start adding volume to the tissue expander slowly over time in clinic. And then at a second operation, we would take out the tissue expander and put in the permanent implant. So that's called 2-stage implant-based reconstruction. Now, where the implant sits is also a potential pathway for 2 options. The implant can either sit on top of the pectoralis muscle, that's in the native breast anatomic position, and that's termed prepectoral reconstruction. The implant can also sit partially underneath the pectoralis muscle, and that's called partial submuscular or subpectoral reconstruction. And there's pros and cons for both options, and both options have pretty similar complication profiles. Just the pros and cons of them vary, and so it is often up to the patient what they would prefer. The third option of reconstruction is using your own tissue. And within using your own tissue, there are kind of 2 pathways. Pathway number one would be to do what's called a pedicled reconstruction. Pedicled means that you use your own tissue, but that own tissue is not ever fully detached from your body. And the most common pedicled reconstruction would be to take the latissimus muscle from your back with the skin and the overlying fat, and you can cut around the latissimus muscle, tunnel it through your armpit, and build a small breast with your latissimus muscle. Now, that's typically not the first option for reconstruction. It's usually more an option if something else has happened, but that is a potential option. The more common form of reconstruction using your own tissue is using tissue from another side of your body, most commonly your lower abdomen, in the form of a free flap. That means that the skin and fat can be taken from your lower abdomen with its own blood supply and be completely lifted off and transferred to the breast and made to live in the breast by sewing the artery and vein together and building a new breast using your abdominal tissue. This is called typically a DIEP flap, a DIEP flap, which stands for the blood vessel that it's based on, the deep inferior epigastric perforator flap. It by far is the most common form of free flap for breast reconstruction, but there are a number of other sites that can be used, including the thighs, the buttocks, the low back. I think that overall is a brief overview of the reconstruction options. I'll now turn it over to my partner, John Rose, to discuss some nuances of nipple-sparing mastectomies, maybe some lymphedema. Thanks so much.
Thank you so much, Dr. Piper. Dr. Rose, welcome on the panel.
Hi there. Thanks so much for having me, and thanks to the other panelists, and thanks to those who are tuning in via Zoom. As was mentioned, I'm one of the reconstructive surgeons here, and so I work with a lot of the cancer surgeons here, and we provide various services in reconstruction. And we'll focus some comments today on some of the stages of reconstruction, as well as oncoplastic techniques, and then I'll talk a little bit about lymphedema because it's oftentimes of interest. So in terms of reconstructive techniques, it all really builds on the foundation that my colleague Dr. Piper just explained, which is that the three avenues exist of being either flat and not undergoing formal breast mound reconstruction, using implants, or using your own tissue. And with the latter two categories, when we're creating a breast mound, either of implants or your own tissue, there are various ways that we can stage the procedure. And I wanted to give an example of that just to describe what I mean. It's oftentimes the case where by the time one encounters the need for a mastectomy, that it can exist in a context of what we call ptosis, which is where the breast descends over time, and or the breast can perhaps not be the size that one would think is appropriate for their body, and we may want to consider making it smaller in the form of a reduction. And as it turns out, especially in the context of prophylactic mastectomies, we have oftentimes the luxury of time on our side, meaning that the goal may be to eliminate all of the breast tissue ultimately, but that we can stage it in order to preserve certain goals of therapy. For example, it was already mentioned that preserving the nipple is oftentimes a goal. But if the breast is either larger than desired and or descended in terms of ptosis, we can oftentimes correct that to a more appropriate size through a reduction and preserve the nipple by adding an additional stage to the process. What I'm referring to is that a standard reduction for breast reduction would incorporate the removal of a certain amount of tissue, of breast tissue, and rearranging the skin so that we can achieve a smaller, still spherical breast mound on the chest. And we can incorporate that into a first stage to set not only the size of the breast, but also the location of the breast so that it's positioned appropriately and anatomically on the chest wall. That includes, of course, the nipple areolar complex. After that stage of surgery, we can then proceed a few months later with a formal mastectomy, but operating this time on a breast whose position on the chest and size has been predetermined by our stage 1. At that time, during stage 2, you would undergo mastectomy and then whichever form of reconstruction you chose, whether it's an implant-based reconstruction or an autologous reconstruction. That extra stage can preserve the nipple. It can also achieve the appropriate size and account for any ptosis that may be pre-existing. We call this type of surgery, where we're combining techniques, oncoplastic surgery, where we're taking principles from the oncology world in terms of risk-reducing surgeries, mastectomies, and we're combining it with techniques from kind of straightforward plastic surgery, which would be a breast reduction. By combining those two techniques into one treatment plan, we can achieve in multiple stages the goals that I've mentioned. Transitioning a little bit into something else, which is a new area of both research and practice, lymphedema is something that's on a lot of our patients' minds. Now, often it's the case that patients who are concerned about lymphedema are also having either lymph nodes harvested and or radiation. If the mastectomies are purely prophylactic, then that may not be a concern of yours. But sometimes patients learn that they have a diagnosis of underlying increased risk for breast cancer because some kind of mass was already detected. In that case, they may have an active tumor.
Lose you, Dr. Rose?
Oh, you did, but I'm back. So I'll pick up right where I left off then. Essentially, in those cases where lymph nodes and or radiation may be planned as a part of your treatment, typically for cancer, then we would want to have a discussion about the risk for lymphedema. If we talk about all comers for lymph node dissections in the axilla and radiation, then the risk is as high as between 20 and 40% for patient populations undergoing breast cancer related surgeries. That's very high. And we now have options to both detect it at earlier stages and also to treat it in different ways. Some of the surgeries that we offer are performed at the time of lymph node harvest, and this would be called a immediate lymph node or immediate lymphatic reconstruction, or ILR. Immediate lymphatic reconstruction is achieved by essentially reconnecting the lymphatics in the axilla to the venules or small veins in the axilla after the lymph nodes have been harvested. The theory behind the surgery is that when the lymph nodes are harvested, it creates a disconnect between the lymphatics and the veins, and we simply reconnect them. It's performed during the same surgery and through the same incision. It only requires an additional step that we map the lymphatics in your arm during that surgery. For this reason, it is a popular treatment option among patients who are concerned that they may be at risk for lymphedema postoperatively. If, however, you're in the unfortunate situation where you develop lymphedema postoperatively, there are also treatment algorithms that exist in that setting in the form of lymphovenous bypass and or up to lymph node transplants or transfers. Each of these procedures are, again, for patients who already have lymphedema, and I'll mention them very quickly just so that they're on your radar. Lymphovenous bypass refers to a reconnection between the lymphatic channels and the veins of the upper extremity, such that it restores flow, just usually at a different site than the previous lymphadenectomy. Usually this means that there's a small incision somewhere along the forearm or arm in the same extremity. Lymph node transfer refers to the fact that we take lymph nodes from one part of the body and we literally transplant them from one part of the body to another part of the body. In this case, usually in the axilla where the lymph nodes were previously harvested, but it may also include a transfer into the forearm of the affected limb. With that, I'll conclude my comments about both oncoplastic techniques and some of the lymphedema concerns, and I hope to hear from you in the panel.
Thank you, Dr. Rose. And I now would like to move on to the gynecological risk-reducing surgery. Dr. Chen, Dr. Alvarez, I think you are setting this up as a conversation.
Indeed.
To you guys.
Thank you. Hi, everybody. I'm Chen. I'm the Division Director for our Gynecologic Oncology program, and I also lead our GYN Hereditary Cancer program. Dr. Edwin Alvarez is our Director for our Clinical Trials program, and we thought we would have a conversation about some vignettes of possible situations where risk-reducing surgery would be coming up. And Edwin, maybe you can introduce some ideas and we can chat about it.
Sure. So I'm going to role play. Please pardon me here. So in this situation, I'm a 40-year-old, never been pregnant person, female, with a germline BRCA1 mutation, desiring future fertility, having been referred to Dr. Chen for consideration of risk reduction. So that's kind of the vignette. And I guess my first question then, Dr. Chen, what are my risks of ovarian and breast cancer?
Right. Thanks for coming in and introducing this conversation. When we think about cancer risk, we think about your risk over your lifetime. So when we think about BRCA1, we're always concerned about an increased lifetime risk of both breast cancer and ovarian cancer, so that we typically think that by the time you reach age 70, the chances of cancer are higher than in the general population. So whereas in the general population, the risk of ovarian cancer is somewhere around 1 in 70, for somebody with BRCA1, we would consider your cancer risk to be closer to somewhere like 1 in 3. So we talk about somewhere around a 40% lifetime risk. But you're 40 now, and so your risk of cancer today is not nearly that high, but the risk of cancer increases as you get older. And what we do know is that people with BRCA1 develop ovarian cancer younger than people who don't have BRCA1. So the setup for risk-reducing surgery is because we ideally would like to consider surgical removal of the ovaries and tubes before the cancer develops.
I see. And so that leads me to ask two questions. One, really, what are the recommendations and are there guidelines? And what if we just observe and wait and treat the cancer if we get it? Is that not an option?
Well, the challenge we have with ovarian cancer is that it is still very difficult to detect ovarian cancer early. We don't have a good screening test. So even though we talk about doing CA-125 surveillance, we talk about the role of a pelvic ultrasound, that's not going to pick up a cancer before it's already become a cancer. For a pap smear, for example, we can pick up changes in the cells of the cervix that are precancerous before a cancer has developed. We can treat those abnormalities, and then that individual will never get cancer. For ovarian cancer, we know that we don't have a good early detection test. We also know that the symptoms of ovarian cancer are pretty vague. And we also know that by the time we find a mass or we feel something, frequently the cancer is already fairly advanced. And so the reason that we think about risk-reducing surgery is because we don't have good early detection. Advanced cancer is a very deadly disease, and we can consider surgery to reduce that risk at the appropriate time. We don't want to just observe, because we know that if you are diagnosed with cancer, most of the time people are diagnosed with stage 3 or stage 4 disease. And even when we find stage 1 cancers, those cancers still can have a high risk of recurrence.
I see. So it's almost like you don't want the cat to get out of the bag, can't put the cat back into the bag.
Mm-hmm.
So you want to try and prevent. I see what you're saying. And so then the recommendations then for risk reduction then are removal of which structures? Or
Well, we
Okay.
know that the ovarian cancer, we feel actually starts in the fallopian tube in most cases, but we do see cases of ovarian cancer that actually start in the ovary. What happens, we believe, is that the cells in the fallopian tube there's much more surface area on the ends of the fallopian tube, the fimbria of the fallopian tube. And so we think that's where most of the cancers arise. They spread to the ovary and they develop into what we typically characterize or feel is an ovarian cancer. So what that means for what structures to remove is that we want to remove both the ovaries and the fallopian tubes when we're considering risk-reducing surgery for ovarian cancer. Sometimes we talk about doing a hysterectomy, but a hysterectomy is not required to decrease ovarian cancer risk. I can't hear you. I think you're muted.
I didn't want you all to hear my dogs or my son who just got home. So, you said that most of the cancer risk comes from the fallopian tubes. Can I just have my fallopian tubes removed?
That's an excellent question. And in thinking about that question, it's something that is being studied, number one, and has been proposed as something that we can do in the general population, number two, to try and decrease ovarian cancer risk. So you're correct. And especially, if you're 40 and you're thinking about the possibility of future pregnancy, one of the things that I would also want to talk to you about is the role of our fertility specialists. But coming back to your question about just removing the tubes, it's felt that if the tubes are removed, we probably can reduce the risk of cancer. But right now, we don't know how much we reduce the risk. And we don't recommend that as the ideal procedure for reducing cancer risk. But for someone who's done with childbearing, who's at a younger age, you can consider removing the tubes. And as a research question, what we're thinking about right now is for people with BRCA1 between the ages of 35 to 50, there is a study that's looking prospectively at people choosing to have either just their fallopian tubes removed or their ovaries and tubes removed. And we want to study that group to look at both of those choices and see what happens from a cancer outcome. So while I recommend removal of the ovaries and tubes, in this situation, I think that we could consider this as a research question. And I think that I would be happy to talk to you more about our clinical trial. And outside of that, I think we would have to discuss it on an individual basis of, why you would only want to have the tubes removed. And if future fertility is that choice, then we also would want to make sure that we connect you with our fertility specialists.
Fantastic. Thank you. Thank you for that. So most of the reduction comes from having the tubes removed. We know that kind of scientifically, but we don't yet have the data to say if removing of only the tubes is as good as removing tubes and ovaries. And as I'm understanding, we have excellent data that removing tubes and ovaries for someone with a BRCA1 mutation actually can prevent cancer and improve survival on an all-cause basis, right?
Yep. You've done your homework.
What's that? Done my homework. Well, got to do that. So kind of taking this in a little bit of a different direction. And I'm 40 years old. I do have a sexual partner. I'm thinking of having my ovaries and tubes removed. Would that just having those GYN organs removed change my ability to have sex or to enjoy sex, I should say?
Removing the ovaries and tubes when you're 40 has the significant consequence of surgical menopause. And having done your homework, I'm sure that we can talk about that a little bit more in detail as well. With relationship to having sex or enjoying sex, we're not removing the uterus. The vagina stays in place, the clitoris stays in place. In terms of sexual function, we know that a lot of that relates to what happens in the brain, to the physical organs. However, clearly, going through surgical menopause can affect sexual, the sexual experience, and also affecting vaginal dryness. And so we would want to talk a little bit about hormone replacement therapy at this point in terms of dealing with menopause. But as far as the ability to have sex, you can definitely still have sex. The ability to enjoy sex is different for different individuals. And it's something that we are always working on, talking about, thinking about what we can do to optimize your experience afterwards.
Okay, this just as an aside, this may lead to other questions from the Q&A panel. So for the panel, so we can leave it there for the moment. This is a good time that you think to switch to vignette 2?
Yeah.
All right. All right. So vignette number 2. So now I'm another patient, completely unrelated, but now still 40 years old. I've been pregnant twice and I've had 2 children. I have a germline mutation in BRCA2, and identified in myself and as well as in my family. And I use an IUD for contraception. Is there any difference in what are my risks for ovarian or breast cancer?
Sure. For BRCA2 compared to BRCA1, we know that the cancer risk is lower than in BRCA1, but it's still significantly higher than in the general population. So going back to 1 in 70 for the general population, we would quote for BRCA2, the lifetime risk by the time you reach age 70, that risk is somewhere around 25%. So maybe 1 in 4 compared to 1 in 70. In terms of the age of ovarian cancer, most of the time, those cancers develop a little bit later than for BRCA1, a little bit closer to the age of ovarian cancer diagnosis in the general population. So as we think about risk-reducing surgery, our recommendation for that surgery is a little bit older than for patients with BRCA1. In terms of the IUD, we do think that oral contraceptive pills do decrease one's lifetime risk for ovarian cancer if you've used the pill long enough. And there has been some studies that look at people who use the IUD may have some decreased ovarian cancer risk as well. The strongest data is for risk-reducing surgery, but these forms of contraception are beneficial for reducing cancer risk. The other part about the IUD is I want to know what type of IUD that you have, whether it's a copper IUD or a progestin IUD. As we talk about risk-reducing surgery, we would consider the IUD as part of our hormone therapy regimen, in that when we give estrogen replacement, we also have to protect the uterus. And in protecting the uterus, a hormonal IUD is often helpful for that strategy as well.
That's perfect. I actually have a progesterone secreting IUD. It was placed last year. So as far as I understand it, I've got at least 5 more years, if not 7, that'll work for me. The recommendation for me then is to remove my ovaries and tubes. Does the uterus play into that also for my BRCA mutation?
You know, for BRCA2, we also recommend removal of the ovaries and tubes. Removing the uterus is a choice. And what could that choice be? The choice would be that, obviously, you know, if you didn't have the IUD, if you had pelvic symptoms, let's say fibroids, or, you know, if you couldn't use hormones or didn't want to use a hormonal IUD, taking out the uterus simplifies the hormone replacement. And so, you know, if we took out the uterus, you could just get estrogen replacement alone. Some people choose that. But on the other hand, if you want to get the minimal surgery for maximal bang for your buck, then taking out the ovaries and tubes is what we recommend. In terms of uterine cancer risk, we don't necessarily feel that BRCA1 or BRCA2 either increases uterine cancer risk, but there have been some studies for BRCA1, not BRCA2, that talk about if you were to get uterine cancer, is that a higher risk type of cancer. But for BRCA2, I think taking out the ovaries and tubes is the current recommendation that I would give you. And unless there's a reason to, Sorry, I don't think that we need to take out the uterus with this surgery.
Okay. And then I'm 40, I'm gonna have my ovaries and tubes removed. Can I use estrogen replacement safely? After I've had my ovaries out, for this BRCA2 or my friend who was here before me who had BRCA1?
So I think that both of you are healthy without a prior history of cancer. And in that consideration, absolutely. And in fact, we definitely want to recommend hormone replacement therapy. In the area of caution for BRCA1 and BRCA2 is when individuals have a history of a hormone receptor positive breast cancer. That could be a reason that we wouldn't want to give hormone replacement. But if you don't, and even in situations of hormone receptor negative breast cancer, thinking about the pros and the cons, risks and benefits, surgical menopause and not, we would want to recommend estrogen therapy, and we would want to recommend it at a high enough dose that you don't have significant menopausal symptoms, that we protect your bones, that we protect your heart, and really help to smooth the transition. And we typically will continue hormone therapy until you're 50.
Oh, I see. At 50, it should stop.
At 50 is the age of natural menopause. And when we look at hormone replacement and the benefit of continuing hormone replacement in the postmenopausal situation, there have been studies that look to say that there's not a strong reason to continue hormone replacement therapy in the postmenopausal individual. But for managing symptoms of menopause, and certainly for early menopause, surgical menopause, we want to recommend hormone replacement until you're 50. At that point, you're following up with someone. Whoever's doing that follow-up can talk about getting you transitioned off of the hormones.
Thank you. And just a little bit of another switch here. So we've talked about the benefits of surgery. We've talked a little bit about risk, including menopause. What are the other risks, and what are the differences in risk between having ovaries and tubes removed or adding a hysterectomy to those procedures?
Yeah, that gets more into the technical details of the surgery. When we do the surgery, we do it laparoscopically most of the time. So it's done under a general anesthetic. We make a small incision in the umbilicus. We make small incisions in the abdomen, and we typically can remove the ovaries and tubes laparoscopically in most situations, unless we find that there is something on the ovary or there's a growth or something that makes the ovary bigger. If we want to do a hysterectomy, most of the time we can do that laparoscopically as well. And when we remove the uterus and cervix, we would remove it through the vagina. Sometimes when there's fibroids or the uterus is very large, we would have to make a small incision to facilitate removal of the uterus. Sometimes we can use a robotic assistance if it's necessary to, from an anatomic or just for procedurally removing the uterus. But most of the time it's minimally invasive. Most of the time people can go home the same day or the day after. And the recovery time that would be expected is about 4 to 6 weeks.
And then those risks then will be things like bleeding, infection, pain.
Yeah, those are the typical risks that we consider. And in adding the hysterectomy, there's slightly higher risk of injury to the bladder or to the rectum, simply because that's where we're doing the surgery. When we're just taking out the ovaries and tubes, bleeding, infection, injury to the local structures, but we're not that down low. So probably a little bit less bowel and bladder complications.
Fantastic. And probably less infection risk too, because we're not going into the vagina. Yeah,
that's right.
Okay. So that's kind of it for my my setup questions.
And we could talk a little bit more about doing timing of the procedures and coordination with our colleagues as we get into the Q&A as well. Thanks.
Okay, thank you all for this excellent introduction to your surgeries. And can I ask you to all come back onto video now? Cheryl, can you turn on your video again? Thank you all. This is really, really helpful. And I think for those who may have come late or not heard this, Dr. Piper and Dr. Plastic Surgery for breast risk reduction. Dr. Ewing is a breast surgeon. Dr. Alvarez and Dr. Chen are doing gynecological surgeries. So I'm gonna just ask a couple of questions that were coming through here, and one is actually, I'm going to ask you this, John, because it's actually a difficult question for me to even go through the acronyms. What's the difference in candidacy between DEEP versus PAP versus TUC versus LD/TDAP reconstructions? I can put it in the chat if you want me to give you this so you can have a look. I'm gonna send this to you in the chat. This is the question for you. You see this in the chat?
Was that to me? I'm sorry.
That was you, John. Yeah.
Yes, yes. Let me look at it now just to make sure. It was breaking up a little bit. Oh, sure. So, thank you for that question, by the way. This was alluded to in part by the comments by Dr. Piper, my colleague, who mentioned that with autologous reconstruction, even after you've made the decision of using implants versus using some of your own tissue, there's still more decisions to be made. And all of these decisions have acronyms in the medical field because we seem to live and die by acronyms. But certainly there are a number of options, even more than the ones that we just mentioned now. The DEEP flap, as Dr. Piper mentioned, is the most common option that is used, where we take tissue from the lower abdomen, and each of these acronyms stands for something, and I'll say it, but you could also probably Google it if you just wanted the words, but I'll describe what the words mean even more so than just telling you what the acronym means. So DEEP refers to DIEP, deep inferior epigastric perforator, and that's referring to the lower abdomen. With regards to the PAP flap, that's a profunda artery perforator, referring to a vessel in the leg, and it's essentially a vessel that comes off the backside of the inner thigh. And so if you think about where your inner thigh meets the area under your buttock, that would be that area. And if you think about another option, that would be the TUG, or transverse upper gracilis flap, TUG. That's referring to a flap that is kind of a similar slice of tissue, but from the front side of your leg, so the front going towards the middle. And the reason it's called transverse is because it's essentially an ellipse that's kind of put on its side like this. And the LD is the one that was referred to by Dr. Piper, the latissimus dorsi, which is typically a flap that is not free flap, as we call it, but it's a rotational flap where we leave it attached on its blood supply and rotate it under the axilla. And so that's some of them. There are others as well. There are S-gap, I-gap. There, we could talk unfortunately for a long time about all the different acronyms, and so I don't want to kind of throw a word salad at you too much, but all of them refer to essentially a set of blood vessels, which then, of course, geographically rotates to a specific part of your body. The important thing, I think, to know from an introductory session like this is that there are various options, and that it's important to consider those options with a surgical team, not just a surgeon, but a whole surgical team, and at a site where they're comfortable with all of these different options, because you certainly want to choose a provider who has all the options available to them and then chooses the best one for you as the patient. Sometimes that may mean the belly, but if, for example, you've had previous scars all over your belly, maybe it's not a good option. Maybe you've had liposuction on your belly and it's not a good option. For those reasons, then we would potentially go to the thighs or the buttocks or even the back and look for other sites where we could take or harvest a piece of tissue that could render itself for breast reconstruction. The thing that all of these have in common, other than the latissimus, is that we typically separate them from your body and then transplant them to another part. And that's performed with microsurgery, which is that under a microscope, we connect small arteries and veins. And that can be delicate work. And for that reason, we recommend that you choose a high volume provider to do, and a provider team to do that. Oftentimes those can be combined with your mastectomy. Sometimes they cannot. And that's a personalized decision for each patient. I hope that helps shed some light.
So John and Merisa, when someone's looking at all these different options, can you be too thin for any of these options? I know I grew up in an area where you couldn't be ever too thin for anything, but could you be too thin for any natural options?
I think that it really depends on the ratio of your soft tissue in another part of your body to your breast size. So in general, if someone has been pregnant before, you know that their abdomen can stretch, and there are some creative ways that we can use abdomen or thighs or somewhere else to build a breast. So it's rare that someone is not a candidate for using their own tissue. There might just be better options yielding better aesthetic outcomes with not using your own tissue. But especially in the Bay Area, where we tend to have patients who are pretty thin, we can still use your own tissue to build you a breast. So I'd say in order to really determine your candidacy, you would have to see a plastic surgeon and be evaluated in person.
Okay, that's actually super helpful. Cheryl, this may be a question for you, and I think this comes up a lot actually. It's like, not talking to the very young, but this participant wrote in, I have a BRCA2 mutation, PMS2, and I had a prophylactic TIH. And now I'm sort of been encouraged to do a mastectomy, but I'm 62. Do I really need to do a mastectomy? I think this comes up a lot, that like a lot of our patients in the hereditary cancer clinic are diagnosed actually later, that they are like in their late 60s, and they go like, well, I've been doing well so far. Do I really need to do this now?
Am I unmuted? Okay.
Mm-hmm.
That's Dr. Munster, that's an excellent question, because there has been a lot of increasing data, particularly in the last 5 years, that have looked at women over the age of 60 and particularly over the age of 70. Particularly if they are diagnosed with an estrogen receptor positive cancer and are treated on hormonal therapy, their risk of a future cancer or a recurrent cancer is not significantly different than the general population. So we're moving more and more towards, for older women, not doing risk reduction surgeries because their risk, or if they want to take hormonal therapy for chemo prevention to prevent cancer, these older women too seem to not have a significantly higher risk than the general population.
Dr. Ewing, you're not considered 62 older, do you?
Yes.
That's a hard blow there.
I'm closer to 70 than not.
All right. I mean, that's actually really helpful, and I think probably reassuring a lot of people, and a lot of it is a personal discussion. Dr. Chen and Dr. Alvarez, do you feel the same way about the ovaries? Someone is 65, do they get to keep their ovaries with a BRCA1 or BRCA2 mutation just because they're older?
I jump in and say that you know, the risk is still there. I don't know about a decreased risk. You know, we have a ton of patients in their 60s who are newly diagnosed with an aggressive cancer that's uncurable. And the trade-off at age 65 is really a few incisions and a day in surgery. There's not that surgical menopause risk any longer for the 65 or 62-year-old. So we would still recommend risk-reducing something.
I completely agree.
Do you want to add?
Yeah, I completely agree. The typical age for ovarian cancer in the general population is in the late 50s, early 60s. So someone who's in their 60s is at the age that's really at risk, and we don't have a good early detection techniques. So, it all is a matter of risks and benefits. So if someone is healthy to consider risk-reducing surgery, we would still recommend it. If someone has other medical comorbidities and problems, obviously every patient, every person has their own choices and we have to counsel them, individually. But I think that would be a not as challenging decision to make in the sense of menopause, childbearing, hormone therapy. But the risk is, what sort of risks you need to have to undertake the surgery, but we would still recommend it.
Thank you both. Can you address the implication of and options for doing aesthetic flat breast reconstruction, including options like swim or Richardson's technique? Merisa, would you like to take that?
Sure. I think that the swim or the Richardson's technique is similar to what I was mentioning with, under the name of Goldilocks. But the idea behind that is it's an alternative to a simple mastectomy that has the potential to give you a small breast mound without needing an implant or a bigger procedure like a free flap. In order to be a candidate for that, you would have to have larger breasts with a larger skin envelope. And then what happens is at the time of mastectomy, the majority of your skin and subcutaneous fat is preserved. After the mastectomy is done, incisions that mimic a wise pattern breast reduction. So that's also an inverted T or an anchor scar, meaning a scar along the bottom of your breast and then straight up and down. That kind of scar is performed, and the subcutaneous fat and skin, where the top layer of skin has been removed, is folded upon itself to be able to give you a small volume at the bottom of your breast. Now, in some places, I think they attempt to preserve the nipple and areolar complex on a little bit of that subcutaneous fat that's left behind on after the mastectomy. So in certain patients, they might be a candidate for nipple preservation that way. Others may opt to have their nipple completely removed and put on as a free nipple graft if someone does desire a nipple after undergoing this kind of technique. Or you could have your nipple and areola removed with a mastectomy specimen and then just have the incisions without the nipple and areola and let it later get that tattooed if you desire.
Thank you. Dr. Ewing, a question for you. If someone is BRCA2 positive and has dense breasts, would surveillance monitoring not be recommended because it would be difficult to detect abnormalities?
Actually, this breast doesn't present a problem the way it used to when we only relied on mammography for screening. With the use of modern breast MRI, it's an excellent way to surveil dense breasts. In fact, we recommend that for women who may be at increased risk to have an annual MRI as part of their surveillance. So we use MRI very efficiently for someone who has dense breast tissue. So it's not an issue.
Okay, thank you. Back to our GYN colleagues, is like a lot. Of course, the really challenging question is like, it's not for BRCA1 care. It's not do I need to have an oophorectomy, but when? When? What's the right time? Is there a right time?
Well, the choices that relate include menopause, big decision-making point, right? Of the recommended age is between 35 to 40. So before the age of menopause, but the second big decision is family building. So on completion of fertility, family building. And at that point, the problem is that in terms of considering choices of hormone replacement, really being able to have a plan and follow up and follow through. So the current recommendation is between 35 to 40. The study that we're looking at for the salpingectomy is considering removing the tubes at the same age. The study allows you to choose whether you have a salpingectomy and when to have the oophorectomy done. And that's one of the outcomes that they want to look at, is seeing when people decide to have their ovaries removed. So, I've seen people choose strategies of removing the tubes when they're done with childbearing and think about when they're taking out the ovaries, we recommend 40. But on study, people have thought about waiting until 50, thought about waiting until menopause. I also have patients who choose recognizing their risk to continue with surveillance and not have surgery. And I also have had those individuals diagnosed with cancer. And so it's kind of taking those risks and consequences into hand and, thinking what is the right thing for an individual. And we will continue to counsel and talk and work with everybody individually. Dr. Alvarez, do you have any other comments?
Not at all. I mean, agreed.
A question from a patient who doesn't have BRCA1 or BRCA2, but has a MSH6 Lynch syndrome. Does hormone replacement therapy increase my cancer risk?
I can jump in here. So it kind of really depends on the cancer, right? So for endometrial cancer, having combined estrogen and progesterone therapy can decrease the risk of endometrial cancer. The question, though, does in the postmenopausal setting, does that increase the risk for breast cancer? And if that's minimal, that would be then probably a question back to you, Dr. Munster.
I don't think we have a lot of evidence that it increases the risk. I think if you look at the WHI, the Women's Health Initiative in terms of hormone replacement therapy, there was a lot of talk about the increased risk for breast cancer, but this really only was the case for estrogen and progestins. When you look at progestin, if you look at estrogen alone, the risk for breast cancer is actually not increased, it's actually decreased. There's actually benefit from taking unopposed estrogens. And I think I really like your idea of being 40 with an IUD that causes progestin to protect the uterus, the organ that's really needs to be protected from progestin, and then give estrogens alone.
Even though in this case, we'd recommend having the uterus out, and then the risk then would really be about breast cancer.
Yeah, and then once the uterus is removed, as Dr. Chen aptly pointed out, then hormonal replacement therapy becomes a lot easier. For us to recommend hormone replacement therapy is a lot easier when there's no uterus. I'm just not sure losing another organ is necessary for that. And I think having been in this situation, it's pretty difficult to give up all the organs if you don't have to. I have a question for you, Dr. Piper. It's like, for reconstruction, I have small breasts and I'm really interested in implant reconstruction for preserving breast shape. But I worry that they feel heavy. And like, if I want a small breast reconstruction, like, is there a smaller size? What can you do there? I think we talk a lot about natural reconstruction, but implants are still an option for many people. Do you mind addressing that a little bit?
For sure. Implants come in such a wide range of sizes. And when I'm thinking about what size implant to use on someone, it has to do with your breast width. So how wide is your breast? We call that the base width. And then how much does your breast project or stick out? And so with implants, we have implants that are very flat, which we call them low projection, all the way up to extra high. So we have a very wide range of implants to accommodate varying size breasts. The smallest implants we have are 80 cc's, which would translate to a breast of 80 grams. Occasionally we see breasts that small. Usually the smaller breasts we see are around 100 grams. And then the largest implant that we currently have is 700 cc's, but implants go up to 800 cc's. So there are a very wide range of implants that are available for varying breast sizes. It's true, I do think that implants are heavier than native breast tissue, so that is an adjustment to make. But if you have smaller breasts and have smaller implants, I don't think that would be a huge difference. I think the biggest issue with implants in women who are smaller breasted is that implants are round. They're round and they're smooth, and that allows them to spin within the breast pocket. But the breast itself is not round. So when a breast is removed, it has more of a teardrop shape or teardrop / triangular shape that goes up towards the armpit. And we are trying to recreate a breast with an object that is not teardrop shaped. And what I see, especially in women who are very, very thin, is that the implants do a good job of recreating a round breast mount, but it doesn't do much to fill the volume up high. In some women, they're candidates for fat grafting, which is where we liposuction other parts of the body, the abdomen, the sides, the upper buttock, the thighs, and we can use that fat and add it in very small amounts to the subcutaneous fat of the breast to help smooth that transition from where the implant is to the chest wall. I think that there are other local options, like using what are called perforator flaps from the back or the side of the breast to help also give a little bit of volume to the breast, but recreating an entire breast without doing a free flap, that becomes very challenging. So recreating a breast from just fat grafting alone is not really a viable option.
Thank you. Cheryl, this is a question for you, is actually, and of course this comes up in every clinic, where it's like, is there anything being done to restore or retain the feelings in the breast if you do a mastectomy? The loss of sensation is a big concern for many people. What's new? Is there anything on the horizon? What's the reason for it? Maybe let's start is, what's the reason why people don't have any feelings in the breast after mastectomy?
Well, the issue,
Dr. Piper. Go ahead.
well, Dr. Piper has done some work in this area, so I'm sure she'll be happy to address this. But the reason for the numbness is that when we're doing the mastectomy, we're cutting in the subcutaneous space. It's the fat that's immediately under the skin, between the skin and the breast. And the sensory nerves run through that area. And then the major sensory nerves are at the bottom of the breast, right at the corners. And it's very difficult to do a mastectomy if you're trying to remove all the breast tissue without cutting through those nerves. So that's the main reason why doing a mastectomy leaves numbness.
And is it fair to say that certain colleagues who promise to leave you with a lot of feelings often leave more tissue behind than maybe optimal?
Well, there's a lot of research that's looking in that, perhaps leaving that tissue there because it's not a very large amount of tissue, but it's unknown the impact for risk of breast cancer for leaving that tissue behind. For most risk reduction mastectomies, it reduced the risk from, whatever your related genetic mutation risk is to less than 1% after a mastectomy. But leaving a coin-size amount of breast tissue on each side, on the right and left side, how that will impact on the recurrences, we just don't have the data.
I will say that, I think that there are two factors that contribute to sensation after a mastectomy. And one is like what Dr. Ewing is describing, is how thick is the subcutaneous fat that's left behind, because we know that the nerve T3 travels within that plane. And usually it's about 1 centimeter or so deep, but people have varying depths of that subcutaneous fat. And so it's hard to really know how much subcutaneous fat can you leave versus how does the breast tissue interdigitate with that to feel that you've done an oncologically safe mastectomy versus trying to ensure you leave enough to preserve T3. So that's one issue. I think the second issue is that when you have a mastectomy, all the breast tissue is gone. So now you may potentially be able to preserve sensation to your skin, but still all of that space in between your skin and the chest wall is insensate. So if you fill it with an implant will never have feeling. It's an inanimate object. And if you fill it with a flap, so some tissue from somewhere else in your body, it will feel warm, but it won't have normal sensation either. So I know that there is a big push towards sensation preservation, and we all want sensation preservation for everyone. I mean, we don't want people not to feel their breast, not to feel their nipple, not to be able to protect their skin or have any kind of erogenous sensation. I mean, ideally, everyone would have that, but realistically, when all the breast tissue is removed, there's still that cavity where there used to be breast tissue and used to be sensation, and that won't be replaced with anything that has the ability to have sensation in the future. Now, there are some studies that are looking at if a free flap, so tissue, using your own tissue, is taken from somewhere in the body and used to reconstruct the breast, and if you can bring a sensory nerve with that and sew that to those cut nerves along the side of the breast, does that have the potential to restore some kind of protective sensation to the breast? I think the studies are very inconclusive, mainly because if we take a sensory nerve with the tissue, we have no idea what portion of that tissue is supplied by the sensory nerve. It could be a small segment, it could be a large segment, and there's no way currently to really identify what area of the flap that sensory nerve provides. And so whenever patients come to me and asking, well, can you provide sensation preserving mastectomies, or can you reconstruct my nerves afterwards? With autologous tissue, with using your own tissue, I can certainly do that. I can identify a sensory nerve, take that with me, use a nerve graft to sew the cut nerve to that, but I can't guarantee that it will provide any form of meaningful sensation.
Thank you. So, question for all of you. I'm BRCA1 positive, and I already had children. I'm approaching 40. What do I do first? Mastectomy, oophorectomy, fallopian tube removal, vice versa, both altogether? Who wants to take this? I'm sure, Dr. Lee Chen, you have had this question thrown at you many times, right?
Yeah, I mean, the question is an important one because sometimes individuals come in with preconceived ideas of familial cancer risk, but we know that someone with BRCA1 has a higher risk whether they have a family history or not. Without it having turned into a free-for-all, we know that we have screening recommendations that we offer for breast cancer early detection. And we know that we don't have a good early detection technique for ovarian cancer. We know that ovarian cancer risk increases after age 40. So without saying who goes first, I would say we would not want to delay consideration of removal of the ovaries and tubes. And that potentially introduces the concept of, can we do these procedures together, which we sometimes try to do, but we also know that there's some coordination, and there's also important considerations of what surgery is being done for the mastectomy and the reconstruction and how we can combine those things together. So being politically correct, I would say, you can't screen for ovarian cancer. We would try to coordinate, but gosh, I'm concerned about ovarian cancer risk, and I would strongly consider removal of the ovaries and tubes without delay.
Dr. Ewing, you're nodding. You agree?
I have to agree strongly with Dr. Chen. We have excellent surveillance tools for breasts, and breasts are external. So we can feel them, we can look at them. We have breast MRIs, we have 3D digital mammograms. So we have, superb screening tools, and we just don't have that same capability screening for ovarian cancer. So when I have patients ask me, which should I prioritize? I take into account too the age of development of breast cancer in their family. For example, if their mom developed breast cancer at age 25, they should probably not delay it. But if it comes down to preference, if they don't want to do a joint procedure, I usually tell them to have the ovaries removed first.
I want to weigh in a little bit from personal experience. Of course, you know, when you're young and a physician, you make a lot of recommendation. I was to tell patients, not a big deal to do a mastectomy and oophorectomy at the same time. Having had both, it was a big deal to just have one at the time. And I would really be somewhat leery to, in my older age, to recommend that someone does everything at the same time, even though it seems kind of nice that, you know, you have all the team aligned in the operating room. And I think from personal experience, it was a lot more mentally challenging to deal with the surgeries than physically. I think the physical part was actually easier, but it is not trivial to lose your ovaries and to use your breasts. And I think take your time. And I think what we really try to stress in the HCC clinic is get your ovaries out as soon as possible, and then start looking for your team, because the breast reconstruction needs a team. You wanna have time. You wanna do it at the right time. You wanna have time to recover. I think Edwin and Lima, you probably agree with me. Recovering from the oophorectomy is probably a bit easier than recovering from a mastectomy. So the mastectomy just takes so much more planning and timing and all this. I think if you can take your time for that, that's really, really helpful. So then the next question is like, what's a typical recovery from a mastectomy with reconstruction?
So it depends. It depends what kind of reconstruction you had. What I always tell people is if you choose to go flat or that Goldilocks procedure, that by far will be your easiest recovery, quickest recovery, lowest complication profile. And typically for that, I'd say it's about a 4-week recovery. I would recommend taking 4 weeks off of work. You'd stay overnight in the hospital. You'd have a surgical drain in each breast that typically will stay about 2 weeks. If you undergo implant-based reconstruction, it depends if you are able to do direct to implant. If you can do direct to implant, that recovery is typically about 4 to 6 weeks. You'll have surgical drains that last about 2 weeks. If you undergo 2-stage, so a tissue expander and then an implant, the recovery from the tissue expander and the mastectomy is about 6 weeks realistically, sometimes a little bit longer, because as you're undergoing the expansions, I feel like you're still undergoing recovery with that. And the expansion process can be as quick as maybe 2 visits for some patients, but maybe 6 or 7 for another. It depends how large your breasts are and how much you can tolerate having your tissue expanders filled in each visit. The second surgery, meaning taking out your tissue expanders and putting in permanent implants, typically there's a minimum of a 3-month gap between the two, but I typically recommend even 6 months. I think that waiting a little bit longer is good to allow your skin to recover after the mastectomy. And after the implant exchange operation, it's maybe 3 to 4 week recovery. With undergoing free flaps, that is a much bigger recovery. So that typically is a 3 to 4 day hospital stay. And I tell patients right off the bat, 3-month recovery. 6 weeks, no exercise, just walking. 3 months, no lifting more than 10 pounds, no core isolating activities. To kind of help decide between implants versus using your own tissue. Implants, both of those surgeries are relatively easier to recover from compared with using your own tissue. But using your own tissue, it's a really big surgery up front, but then there's less commitment long-term. Hopefully that helps.
Mm-hmm. So we talked a lot about BRCA1 and BRCA2. It's like a question is CHEK2 mutation included in the list of potential candidates for mastectomy and oophorectomies?
Not at this point for oophorectomy, but obviously we would want to follow a person's family history and see if there's a significant family history or other risk factors.
So we do risk-reducing surgeries for CHEK mutation carriers, particularly if they have an associated family history. But it's a discussion. Their level of risk, family history, and if they want to proceed with the risk-reducing mastectomy or surveillance.
Thank you, Cheryl. And a follow-up question for you. Can you speak to chemo prevention for BRCA2 with tamoxifen or raloxifene? or BRCA1 or CHEK2 or ATM?
Well, I'm a little leery about using hormonal therapy for the BRCA1 mutation carriers because they have a higher risk of a estrogen receptor, progesterone receptor negative cancer, which will not respond to hormonal therapy.
Chemo prevention, Cheryl.
No, for
Tamoxifen.
prevention. For the BRCA1s because of the because oftentimes they're receptor negative. For the BRCA2 patients, particularly older women, I have a number of women in my practice who fall into that category.
Thank you. Does nipple sparing mastectomies affect residual risk?
No, because all of the underlying breast tissue is removed. We actually wear telescoping glasses to make sure that we remove the breast tissue. And there has been no data that has suggests that there's increased risk for recurrence in the nipple areolar complex. In fact, most recurrences, if they happen, and again, we're talking 0.91%, 0.9%. The risk when it happens is usually in the lateral breast because that's where what we call ectopic breast tissue is microscopic breast tissue that we can't see. And so when we see recurrences for mutation carriers after they've had a mastectomy, that's the usual location, not under the nipple.
Hey, thank you. Dr. Piper, this I'm sure comes up a lot too, like the recent introduction of doing implants above the muscles versus under the muscle. What are the pros and cons of each?
Yeah. So in 2005, something called acellular dermal matrix was introduced to breast reconstruction. And now it's used both in under the muscle and over the muscle. When an implant is partially underneath the muscle sits on top and the acellular dermal matrix sits on the bottom. So to create almost like a sling or a hammock for the implant. When the implant sits on top of the muscle, it's covered entirely on the anterior surface or the front of the implant by this acellular dermal matrix. So acellular dermal matrix is used both with prepectoral and subpectoral reconstruction. There's pros and cons of either technique. And in a nutshell, the pro of going underneath the muscle is that you have an extra layer of tissue between the implant and the outside world. So it theoretically can make rippling a little bit less. If someone has very poor skin quality, it can help thicken up the skin a little bit. The cons of going underneath the muscle is there's some detriment with cutting the muscle, some increased pain and potential functional loss with doing that. With going on top of the muscle, you avoid cutting the muscle. So potentially less pain, less functional problems, but you have less tissue above the implant. So the underlying implant could be a little bit more visible, meaning more rippling with going on top of the muscle. The final thing to consider is something called animation deformity. Animation deformity only occurs when the implant is underneath the muscle, and it's when the muscle becomes adherent or it sticks to the skin on top. And whenever the pectoralis muscle is activated or fired, it can cause some rippling or dimpling of the skin, and that can cause the implant to move. In general, I try to put the implant on top of the muscle in younger women, healthier women. I try to go underneath the muscle in women who I'm worried that their skin might be very thin and might have a significant amount of rippling. I try to avoid cutting the muscle if someone is very active because I worry that animation deformity would be really noticeable in them.
Thank you. Now, a question comes up for trans men who have genetic cancer risk. Does top surgery, which I understand is not a real mastectomy, lead to any reduction in risk of cancer?
Cheryl, do you want?
So we know that doing a breast reduction does offer some decreased risk just because there's less breast tissue to get cancer. But if a man wants, if a woman wants to transgender to a male defined chest, that we can offer nipple sparing mastectomies. Sometimes we'll do a reduction first and then do the mastectomy. There's various ways that we can do transgender top surgery.
And what I tell patients who come to me looking for masculinizing chest surgery in the setting of undergoing a mastectomy for risk reduction is the aesthetic outcomes are quite different, because the mastectomy to undergo, for example, a double incision mastectomy, that's a subcutaneous mastectomy. So the flaps are much thicker than a mastectomy for cancer prophylaxis. And so the appearance is quite different. And although there is a risk reduction with the double incision mastectomy, it's not zero. And so if you're undergoing that surgery, thinking about how will you get imaging going forward is very important.
Thank you. If you choose oncoplastic surgery with a stage 1 before mastectomy and reconstruction, what's the timeline for each stage? How long from start to finish?
It's my preference to wait about 3 months. I think that in the setting of cancer, we can do it as soon as 6 weeks after, but I think ideally waiting 3 to 6 months after undergoing a reduction or a breast lift to mastectomy is ideal.
I agree, the longer the better. In fact, I try and even push it to 4 to 6 months, because the longer we wait, the better the skin will recover after the final reconstruction.
Okay, can we talk a little bit about our patient with Lynch syndrome? Any recommendation, Dr. Chen, Dr. Alvarez, and oophorectomies, hysterectomies, endometrial biopsies? We talked a lot about BRCA1 and BRCA2. What about our Lynch patient?
Well, Lynch patients are all different depending on the gene that they carry. So first off, we don't think of Lynch syndrome as one thing anymore, but whether somebody carries MSH2, MLH1, PMS2. The reason it's different is that the cancer risks are different. We think about, for gynecologic cancers, endometrial and ovarian cancer risk, but we know for PMS2, for example, that the ovarian cancer risk is quite low and not that much higher than in the general population. So depending on the gene, we would consider the role of risk-reducing surgery on completion of childbearing. For endometrial cancer, many people still have symptoms of bleeding, so it can be detected earlier by symptoms. We also have had people that we've done endometrial biopsies on with regular periods that we've found endometrial cancer in somebody with Lynch syndrome. So there may still be a role for endometrial sampling. The ultrasound and doing CA-125s for ovarian cancer early detection probably plays less of a role unless you're trying to make a decision, for not doing surgery. But we typically will consider talking about symptoms of endometrial cancer, talking about symptoms of ovarian cancer. We'll consider the role of doing endometrial biopsies. Sometimes we incorporate ultrasound. And then depending on when people are done with carrying pregnancies, think about hysterectomy and then removal of the ovaries and tubes. With Lynch syndrome in particular, because people can be done with having pregnancies much earlier than they're thinking about the role of surgical menopause and just with the risk of cancer, there's been some strategies of hysterectomy followed by delayed oophorectomy in the management of Lynch syndrome as well. The other challenge with Lynch syndrome is just the numbers are never going to be as high as what we see with BRCA1 and BRCA2. So a lot of these are guidelines that we think about for recommendations, but there's not a study necessarily that we can quote, nor is there one being done currently to be able to answer that question distinctly.
And Lime, thank you for bringing this up, because we would not put BRCA1 and BRCA2 in one bucket anymore, because they're very distinctly different. And I think nor should we do Lynch syndrome patients. I think when we started this workshop, we were focused on more BRCA mutation carriers. I think there's a lot of interest in other mutations, and we're trying to create a little bit more granularity what we address and what we do. So for the attendees, please forgive us if we are like bucket mutations still. I think as we go on with this workshop, we get better. We also 3 minutes before the end, and I would not want to be remiss in thanking every one of you for this amazing amount of information, and so nicely put. I think our patients are enormously grateful, and I remember when I had to show up for my surgery, I was very overwhelmed, despite the fact that by that time I already spent 25 years in oncology and thought I knew everything there is. When it's your body and your risk, everything looks very different, and it's very hard to really understand what's going on. And I think all of you probably would agree with me. Do come to a consultation with a friend, with someone who can take notes for you. Doesn't have to be your spouse. The spouse may not often be the best person. Being someone who can ask the questions that you don't dare to ask, because you may just be too overwhelmed. So I'm gonna ask you all to give a couple of ending sentences. Edwin, why don't you start?
Ending sentence, I guess. Well, thanks for having me, and I hope this is helpful. And that's it. Thanks so much, Pamela, for inviting.
Good to have you, Edwin. Cheryl?
I'm sorry that my four-legged babies are barking in the background. But one of the things that I have discovered over the years, that a number of women who come to me with a breast cancer diagnosis are high risk, and they had no idea that they were high risk, either based on their family history or some other atypia or some other factor. So if you think that you may be at risk for breast cancer, either from a family history or a history of atypical hyperplasia or some other entity, it's just easy just to do a consultation and be screened.
Mm-hmm.
Because we have very, very good surveillance tools now for breast cancer.
Thank you, Cheryl, and thank you for being here.
Well, thank you. And again, I apologize about my furry babies.
Merisa?
Yeah, no, thank you for hosting this. I think that there is so much information. It is very overwhelming, especially when you're dealing with a cancer diagnosis or learning that you're at increased risk, to process all of the reconstruction options. And I think that having talks like this where you can hear it multiple times is incredibly helpful. I would encourage us to maybe do this a little more frequently.
Thank you. And really great to have you, Merisa. Lime?
I'm grateful to this venue for us to talk, and the Hereditary Cancer Center for really bringing together a team of experts. And I have the pleasure of working together with them. I encourage continued communication for patients to talk about it, for us to talk about it, for people who aren't patients, who are healthy, to feel comfortable having conversations about, they can talk about breast cancer, but gosh, for GYN cancers, I think people, they always tell me, I didn't realize. And, I feel like, where did we miss the messaging? And certainly for this audience, you're interested, you're hearing about it. For anyone who carries a gene, if you're comfortable talking to your family about it, letting them know, because this is kind of why we exist, the Hereditary Cancer Clinic. It gives them a place to be able to come. And it does take many conversations. So communication, talking about it, working together. Thank you for the opportunity.
And this is really why we created the Hereditary Cancer Clinic, for people to have a home to come multiple times, that not nothing has to be decided in the first visit, and you can come back as many times as you want. And I think, and bring the family members, and it took my brother a solid 5 years to get tested. Some people take longer, and he's now in a good screening program. So I think it's important to have a home, and more importantly, we felt like if you are home late at night and you find something on your body, you have a phone number to call, and we will be there. So with this, I like to thank you all for attending, and it's a pleasure to have you all. Thank you so much for all your contributions, and have a wonderful night.
Thank you.